Okay, we're continuing with the hidden history of health by me, Pete Rogers, and we're talking about back pain. And by the way, I'm the best doctor in the world for back pain. There's nobody even in my ballpark. This is a book I wrote. I've written 3 books on back pain and spinal degeneration. Here's one of them, Prevent and Reverse Back Pain. That's my most recent book, my most up-to-date book. And one of my doctor buddies said something funny to me. He said, you know what you're like? He said, you're like the basketball player with the New York Knicks. It's that Jalen Brunson guy. Everybody thinks that he's going to be no good, but he ends up being like the best player. They go, he's short, he's kind of ugly, he's kind of slow, and he's only 33rd pick in the NBA draft, but he ends up being the superstar for the Knicks. Okay, and so what he says is, you're like that. Everybody hates you, nobody will interview you, but you keep coming up with the right answers and stuff that helps people. You're like, like McDougal. He said that's just a fact. And so I'll take it. None of these guys want to interview me because almost all of them are high-fat phonies. They're making money selling fat or something similar. And there's some other really good ones, but, it's because I'm too confrontational, I guess, or something. Because I know they'll interview Esselstyn, and he recommends a low-fat diet, but he's more gentle and mild and pleasant. And McDougal also, a lot of people, were okay with him. But he got in before censorship really ramped up. Anyways, okay, what's the scoop on back pain? It's real simple. I got to show you a picture, though. With a picture, it'll make sense real fast. Okay, I used to run a spinal injection clinic. I've seen, over 100,000 spine MRIs and CT scans. I look at them every day and talk about them every day. I've done hundreds and hundreds of procedures on the spine. I've probably done about, 650, 700 procedures on the spine. Okay, so here is a spine. This is the sacrum, so S1, S2, sacrovertebra 1 and 2. These are the lumbar vertebrae. L5, lumbar L5, L for lumbar 4, lumbar 3, 2, 1. Okay, so here's what happens. These are the disc spaces, and they get degenerated over time due to a lack of blood flow. Here's the abdominal aorta running in front of the spine. The lumbar arteries come off at the mid-height of the vertebral body, and they give a small little branch called the lumbar artery, a little branch down to the end plate. There's an upper and lower end plate, and then by diffusion, oxygen and glucose, actually they're anaerobic, the disc, glucose goes to the disc. The disc is alive. It runs on anaerobic glycolysis. Then it expels its waste product, which is diffused into the end plate and are carried away by blood flow. So when you get all this atherosclerotic, these orange things are atherosclerotic plaques on the back wall of the abdominal aorta, you stenose, meaning narrow and occlude your lumbar arteries, and you will diminish the blood flow to the disc. Then the disc will start to fail. The outer part of the disc is an annulus fibrosus, like a steel-belted radial tire. The inner part in the center is the nucleus pulposus, like a jelly donut. When you drop the blood supply to the annulus fibrosus, it cracks, and then the nucleus pulposus starts to leak out. That's a disc herniation. It'll also start to dry out. That's disc desiccation. When the disc dries out, it loses height, and that'll be disc-based narrowing, and that is, degenerative disc disease. The disc normally helps to equilibrate the weight distribution when the person bends side to side, forward and back, carries a weight, etc. So when the disc dries out and desiccates, it no longer can equilibrate the weight so effectively, such that you start to have a little bit of abnormal motion. The VB above and below the disc, as well as the disc together, is called a segment. And again, the disc is alive. When the disc fails, the purpose of the spine, the reason why you got bones around your spinal cord, which would be in here, the reason you have a skull around your brain is to protect it. So when the spine starts to sense, it has a lot of proprioceptors to sense abnormal motion, it'll lay down bone, and these bone spurs, one will grow from above, one from below, and then they'll contact each other and they'll fuse. So this is called a bridging osteophyte, bridging between the vertebra below and the vertebra above. Then the name, when you see several of them, it's called DISH, diffuse idiopathic skeletal hyperostosis. And the books are real stupid. The books will say things like, you'll also get bone spurs growing and fusing on the posterior aspect of the disc right here. The posterior aspect of the disc is in contact with the PLL, the posterior longitudinal ligament. So you will ossify it, and that's called ossification of the posterior longitudinal ligament. The textbooks back in the 1990s would say, OPLL is a very rare thing, more common in persons of Asian descent. BS, I see it all day long, every day in Western American patients, and the incidence of DISH and OPLL has become a lot more common. You'll also calcify across the disc space, and you'll fuse across the vertebral body, so that's called interbody fusion. There's a ligament in the back here called ligamentum flavum. OLF is ossification of ligamentum flavum. That's less common. I see it, but not as much. And I don't have the spinous processes drawn in here, but they'd be a little bit further back here, and you can fuse across the spinous processes. That has a unique name that's called Bostrup's disease. So the point of the matter is I was aware of a paper saying that abdominal aortic aneurysm was associated with increased risk of degenerative disc disease back around the 1980s. But I figured out that it's all the same thing. All of these fusion responses are a response of the spine to fuse segments of segmental instability. And it's like I think it's a Ralph Waldo Emerson quote, the hedgehog is only one trick, but it's the best trick. It plays dead, the other animals leave it alone. The spine is only one trick. When it senses abnormal motion, it fuses that segment. And most commonly, it fuses through an anterior bridging osteophyte or a lateral bridging osteophyte. But it'll fuse through OPLL, it'll fuse through OLF, it'll fuse through Bostrup's and the spinous processes, it'll fuse through interbody fusion, whatever way it can. Then you get what's called adjacent segment accelerated degeneration, whereby now there's more weight and stress and tension placed on the level above and below the fused level. So that one will start to fail more rapidly. And as soon as it fails, then the process repeats itself all the way from the sacrum, the pelvis, up to the skull. So patients will get this all the way up and down their spines. And then their spine is stiff and it hurts. This is the old guy walking with a cane, then a walker. And then they don't exercise much, their muscles atrophy, they fall, they can have really bad fractures. It's like snapping a piece of chalk, so they call that a chalk stick fracture. You can look it up in 5 seconds. It's very much like a chance fracture, a seatbelt fracture, and I've seen them where they'll transect their thoracic spinal cord, or their cauda equina, or the conus, and they'll become paraplegic from a minor fall, just getting up from their little scooter to their to a chair. And by the time these guys are in so much pain and can barely walk that they end up with those little scooters, they're often dead, within 2 years of that or even 1 year. You got to use it or lose it, man. If you stop moving, it's harder to keep yourself healthy and keep yourself going. Okay, so anyways, that's the Peter Rogers, MD, ischemic and biochemical theory of spinal degeneration. The other thing with what's the biochemical component? Meaning the ligaments are made out of collagen. Collagen is a triple helix, tightly wrapped. If you damage collagen synthesis, you'll weaken the ligaments of the spine. You'll predispose to segmental instability. Well, what will do that? Well, every third amino acid in the triple helix of collagen is a glycine, okay? And it's thought that glyphosate, which is like glycine phosphate, that's an oversimplification, but it's accurate enough for our purposes, can substitute with it, and it'll then weaken, because glycine has a small side chain, but glyphosate has a bigger side chain equivalent. So it makes it harder to wrap that collagen tight, makes it weaker, and it'll predispose to segmental instability and ending up with DISH and OPLL and interbody fusion and all this stuff. Lack of fruits and vegetables. You need your vitamin C, which you get largely from fruits and vegetables, to hydroxylate your prolines. A lot of the amino acids on collagen are hydroxyprolines. So that's a post-translational modification to hydroxylate the proline, okay? So you need your vitamin C. Cigarette smoking, alcohol, fluoride in your tap water will mess it up too. If you look up fluorosis of the spine, especially in areas where there's endemic fluorosis, high amounts in the water, you'll get a lot more fluorosis of the spine, which looks just like DISH. So, fluoride's in the tap water in most places. And most municipal tap water in Western civilization, they got that in the water. It's rat poison, it's toxic. And it weakens collagen. So those are all things contributing to it. And then there's other things people say, well, how do you know? How are you so sure? Well, I also have what you would call consilience, whereby those are pieces of inductive observational evidence that whenever a patient, like a young guy, falls off a ladder, he fractures a vertebra at one level, he gets localized segmental instability due to the fracture. It could be a burst fracture, it could be a compression fracture. He'll form bridging osteophytes at that level within the year, okay? So the spine's trying to fix itself. And he won't have degenerative disc disease at other levels, so he won't necessarily have it at any other level, but he'll get it right at the fracture level. Okay, you also see it when people have a post-surgical fusion, like let's say a pedicle screw fusion, posterior instrumented fusion. They'll then get the same segmental instability, accelerated segment degeneration above and below, and then earlier onset of these bridging osteophytes like DISH and whatnot above and below. You see it in anthropology studies when they dug up the European graveyards. The aristocrats had a lot DISH and things like this in OPL and whatnot versus the peasants did not, because the aristocrats were eating all the high-fat diets. They got enough money for meat. The peasants did not. Then another piece of observational evidence, consilience, would be like, an example would be like that surgeon. I was an MIT surgeon, and now I'm alone in the mountains. His name is Gooby and Dooby for his YouTube channel. I think his dog's names are Gooby and Dooby. He was an MIT trained spine surgeon, and he quit being a spine surgeon because he said he was frustrated. If he would delay the case for 2 months for whatever the reason, and the patient would eat a plant-based diet, start walking, getting their sunshine, quit smoking, eating a plant-based diet, they would often get better on their own. And he also said he could do perfect surgery and patients wouldn't get better sometimes, and he was frustrated by that. You can get decreased pain once you do all these things because you improve blood flow. And a lot of times the pain of the nerve can be due to ischemia, lack of blood flow to the nerve. So you switch from high-fat diet to low-fat diet and decrease your dietary sodium as well. Lack of the sodium, you get vasodilation, the arteries start opening up. And with the low-fat diet, you don't get the clumping together of the red blood cells. You don't get the rouleau formation, the blood sludge. So you get better oxygen delivery to your tissues. Okay, and you avoid caffeine. You don't get the vasoconstriction effect. You get your sleep. Then that lowers your cortisol, your catecholamines. You avoid caffeine, you manage your stress, all of those things, and you get better blood flow to the nerve, and that can make symptoms be reduced or go away. So anyways, that's the major scoop, and I say that because everybody always gets a spine MRI. Do I have a disc herniation? Is there a big disc herniation? Do I need to go to the operating room for a discectomy? At what level should we inject the epidural steroids at? And what I'm trying to say is, I usually don't see a big disc extrusion. What I see all the time in back pain patients is degenerative disc disease. I see this stuff all day long, every case almost. 95% of the cases, more of them, do I see degenerative disc disease in dish, okay, versus a disc extrusion. Yeah, I see them, of course, once in a while, but I don't know, maybe 1 out of every 6 or 7 cases, whereas I see this on almost every single patient. Anyways, I hope you found that helpful.